de-escalation. Secondly, to determine the extent of surgical procedure and to plan the adjuvant therapy. And here, to put things in perspective, I must say that the incidence of axillary nodal metastasis in Indian population is as high as 60%. So we cannot ignore the axilla. Therefore, we must look for axillary nodes and look hard, because the axillary nodes often merge in the surrounding fat and muscle. As you can see here, it, it is barely visible. But the moment you switch on the harmonic, that is the tip for the radiologist, always switch on the harmonic mode on your ultrasound, and that makes the the lymph node cortex very prominent. So that's a way to pick up small nodes as well. A meticulous technique is very important for us to be in sync with the surgeon. And I say it a number of times in my talks that the surgeon's axilla and radiologist's perception of axilla often doesn't match. So all the radiologists should begin to know what the surgeon calls level 1, level 2, and level 3. And so when you're looking for level 1 nodes lateral to the pectoralis minor, it is almost lateral side of the breast and very low down in axilla. Whereas I see residents performing the ultrasound deep in the axilla. No wonder they miss several lymph nodes which are palpable to the surgeon, and thus the surgeon loses confidence in the radiologist's capability to pick up even palpable nodes. So that doesn't augur well for the radiologist. So for my residents, I often draw on the patient's breast where the projected pectoralis minor is, where the projected pectoralis major is. And now you can see for yourself that for level 1, I have to look in this area. And this area is actually not even in the reckoning. Level 2 will be here and level 3 will be here. So once we know where to look, things become easier from there. So certain landmarks which we must note on ultrasound are the pectoralis major, and below that a smaller pectoralis minor. You will notice the fibers of pectoralis major and minor are perpendicular to each other. That is because of the direction of the muscle, the orientation of the muscle fibers. So when you are seeing longitudinal fibers of pectoralis major, you see a transverse section of the pectoralis minor. So that's how you are able to recognize the two muscles easily. So whatever is lateral to minor will be level 1, whatever is behind will be level 2, and whatever is medial will be level 3. I'll quickly take you through the levels and how level 1 nodes are seen here in the lateral part of the breast. Here is a level 1 node. And once we start recognizing these landmarks, our reporting of axilla becomes very accurate and impressive for the surgeon. And they will believe you more and more. So this is level 1 lymph node, pec minor you can see, and major you can see. In the level 2, you have the longitudinal fibers of major, the transverse fibers of minor, and behind that there is a level 2 lymph node, and you can see the placement of the transducer. Level 3 nodes we encounter less often, but that's where we need to look for it. Almost level 3 is the same as infraclavicular location. So that is the level 3 lymph nodes. So now we know that we must look at lymph nodes, and now we know where to look for them. So what does a suspicious lymph node look like? To go to that, let me start with the normal lymph node, and you see a low power picture of the lymph node on histopath matches so well with the ultrasound picture. So the black one is the cortex, the white is the hilum. So this fat is the hilum. The hilar fat is white and the black is the cortex. And a higher power picture shows you the sinusoids, and the green markings that I have made show how the lymph flows from the subcapsular sinusoid to the sinusoids between the cortical area and then into the medullary sinusoid. So that is the direction of the flow. Why it is important to understand this flow of lymph node, because depending upon where the cancer cells lodge themselves and grow, the appearance on ultrasound will differ. So suppose the metastasis starts right in the middle of the cortical sinusoids, and then the cancer grows in both the directions, towards the cortex as well as the medulla. So what do you get? A symmetrical thickening of the cortex. And you can see in these examples, the cortex is symmetrically thickened. We take 3 millimeter as the upper normal limit of cortex. So more than 3 millimeter thickening, which is symmetrical, is abnormal. What happens if the metastasis starts near the outer part of the cortical sinusoid or in the subcapsular sinusoid? What you'll get is an outer cortical bulge, and what you'll see on the ultrasound is an outer bulge in the cortex, sometimes likened to the Mickey Mouse ears. On the other hand, if the metastasis is starting near the inner part of the cortical sinusoids, what you will see is the growth of the cancer cells towards the hilum, and it looks like a rat bite sometimes. So it is called a rat bite kind of lesion. So you have a indentation of the hilum so this is a growing rest of cancer cells, which is much bigger in this example. And you can see a normal cortex of a lymph node and another lymph node, which again is abnormal. So these are typical signs of suspicious lymph nodes. Once the metastasis grows a lot, the hilum gets pushed to a side. For example, here, it is all pushed to a side. And then ultimately, the entire node is replaced by the tumor. Not only that, perinodal invasion may occur, which is seen on ultrasound by seeing this fuzzy outline of the lymph node. It is no longer sharp. It is indistinct and fuzzy. So in our clinical scenario, we often come across axillary lymphadenopathy, even in normal patients. So in cancer patients also, a number of times it's difficult to decide if the axillary node should be deemed as, reactive hyperplasia, likely benign, or suspicious. So are there any practical tips for that? Otherwise, we'll be biopsying too many reactive lymph nodes in these cancer patients. So this is, I have collected images from cancer patients. So these are the axillary lymph nodes in all known cancer patients. So the ones which are marked in red, I will right away call them suspicious because they have cortical bulge, they have asymmetric kind of thickening of the cortex, whether it is towards the inside or the outside. So I know that these are suspicious. So these will go straight away for FNAC. What about these nodes? Now this is symmetrically thickened. This is more symmetrically thickened with a central hilum, and this is entirely replaced by tissue, but I don't know whether it is inflammatory reaction or it is malignancy. So I need to have a tiebreaker for these situations to decide whether I want to go for a FNAC or not. So first of all, I will look at the adjacent nodes. So if you see an abnormal node, even if it is a symmetrically thickened cortex, but next to it is a completely normal node, and it's a known patient of cancer, immediately I would think of metastasis, because inflammation would tend to affect all the lymph nodes in a regional chain at the same time. So that's a very simple thing, but it helps when you look at the adjacent nodes. Sometimes all the nodes are abnormal in the axilla. As I said, inflammation might have affected all the nodes, but now with advanced cancer, you don't know whether all the nodes are metastatic. So what do? The second tiebreaker, you will look at the contralateral axilla. So if there is a right to left asymmetry, for example, here you see in the left axilla, there are several nodes which are thickened symmetrically, some more, some little less, but all the nodes look abnormal, they could be reactive. But when I look at the right axilla, which is the uninvolved side, the lymph node is completely normal. So this would again, for me, favor likelihood of metastasis, and I would like to sample this node. Color Doppler can also help, because if you see a peripheral flow, that is more suggestive of a metastasis. So now we have a fair idea of how to fix suspicion onto the lymph nodes. But I would say that it is very important that you do not rely only on the morphological features on ultrasound. You must confirm or refute the metastasis by doing an ultrasound guided FNAC or a biopsy. Biopsy is quite safe in the axilla because, as we saw, the nodes are well away, especially the level 1 are well away from the axillary vessels, and there is really no risk. I have been doing axillary node biopsies for last 15 years, touch wood, without any problem. In fact, with an automatic gun. So the first step is to identify the suspicious lymph node. Second is to position the biopsy needle in the node and to keep it parallel to the cortex so that you get maximum tissue, and then you fire the biopsy gun and get tissue, and even one good core is good enough. If you are a little skeptical about using an automatic gun, you could go for a semi-automated core needle. They are also very good for lymph nodes, in which the advantage is that there are 2 steps to the biopsy. One, you preload the needle in which the trough of the cutting edge is open. And so this is the final position. So this is a lymph node and you have placed. Now, when you will fire, the needle will not jerk ahead as it does in an automatic gun. Simply the outer cannula will close over this sampling notch. So it is much safer. So if you are not feeling adventurous enough, if the node is close to the vessels, you can go ahead and use a semi-automated core needle. And this is the kind of sample you will get, which will not float or sink because it has partially the lymph nodal material and partially the fat. And a single good core is enough for the pathologist. So in our institution, a recent study has shown that once you add ultrasound guided FNAC, the accuracy of ultrasound goes up to 88% from 70%. So ultrasound alone is not enough. We must supplement it with ultrasound guided sampling. So the algorithm, which is well established for axillary staging in clinically node negative patients, is they should all undergo a thorough axillary ultrasound. If the nodes are normal looking, the next step is sentinel lymph node biopsy. However, if you deem the nodes to be suspicious, they should be subjected to an ultrasound guided FNAC or a biopsy. If they are malignant, then they straight away go for axillary dissection, obviating the need for any sentinel lymph node biopsy. On the other hand, if they are normal, we can't just leave them alone. We will have to take them up for SLNB. The reason being that inherent to every sampling technique, there is a possibility of inadequate sampling, micrometastasis being the most common cause, and you may have missed cancer on your core biopsy or FNAC. So you must take these patients for a SLNB. Now coming to the next part, the focus of today's webinar, can the same algorithm be followed in patients who have become clinically node negative after NACT? So this is the topic of debate. And the reason is that SLNB does not remain all that reliable after the patient has taken neoadjuvant chemotherapy, because the lymphatics undergo fibrosis, the nodes and the diffusion of the dye gets impaired, and therefore the accuracy is definitely hampered. And so you end up with an unacceptably high false negative rate of various studies have quoted from 12 to as high as 18%. The Z1071 trial in 2013 put it at 12.6%. So what happens is that once a patient has come with lymph nodes in the axilla, and then she's given chemotherapy, irrespective of response, they all undergo ALND, and which is definitely an overtreatment, because it has been seen again in the Z1071 trial and several other trials that of all the patients who receive NACT, approximately 40% show complete nodal response. So these 40% patients who do not have any metastasis in the nodes have been overtreated by ALND, which is a potentially morbid procedure and adds to the misery of the patient. So how can we reduce the FNR of SLNB after NACT? That becomes the study question. And in here came the importance of ultrasound clipping or ultrasound marking of the metastatic node before NACT started. That is because this will provide you with a marked node which is proven metastatic and which you can, see the response in that. And sometimes that node may not be the sentinel lymph node. That is why you must have the clip inside. And what you do is you remove the clip node in addition to the sentinel lymph node for a more accurate axillary staging. This has been named as targeted axillary dissection. Instead of a complete axillary lymph node dissection, you do a targeted axillary dissection in which you remove the sentinel lymph nodes, the clipped nodes, and any palpable nodes. So this was pioneered by MD Anderson, and they called it targeted axillary dissection. So these are the two major trials which have shown that once you add ultrasound clipping and a targeted axillary dissection is done, the SLNB reduces to below 10%, which is the acceptable figure for clinical use. And it was also seen that in 20 to 25% patients, clipped node was not picked up as SLN. So that means if only SLNB is used, definitely you would miss out on the lymph node which was malignant. So this motivated me to undertake a study in my institute, which we have just completed, in which we tried to see the feasibility in our setup of ultrasound guided wire localization and surgical removal of clipped pre-treatment positive axillary lymph nodes to increase the diagnostic accuracy of SLNB after NACT. So we started off with 69 patients and had to exclude a number of patients. And finally, because only 32 patients underwent surgery at our institute after completing NACT, and these were my study population. So at the baseline, as you can see, all the features that we have seen of suspicion, these are the suspicious features of malignancy in these patients. And then we did an ultrasound guided biopsy of the node with maximum cortical thickness. Even if there were 3 or more nodes, we only chose one node for biopsy, and the clip was placed in the same node. And you can see that there is good sonographic visibility of this clip within the lymph node. After the NACT was completed, the lymph node could be identified because of the clip. If it could not be identified on ultrasound, in 2 patients, we had to resort to a stereotactic wire localizations. Otherwise, in 30 patients, we could see the clip well on ultrasound. And we did, there were both options. If one of us could go to the operation theater and show intraoperatively the lymph node which had the clip to ensure that that is to be removed. That was done, or if not possible, we placed a hook wire in the lymph node on the day of the surgery. You can see here a level 1 lymph node which has been marked with a hook wire on the day of the surgery. And sentinel lymph node biopsy was done. Methylene blue either alone or fluorescent dye was used in 4 to 5 patients. Unfortunately, due to COVID situation, the radioactive material was not available, and we missed out on doing the dual tracer technique. So it was more or less only methylene blue, and the localized node was removed along with the sentinel nodes. And then all the patients underwent ALND as is the practice. So the idea was to see the feasibility and to compare whether it is possible to do a targeted axillary dissection and obviate ALND in some of the patients. As expected, a large proportion of patients had advanced disease. Most of them had more than 2 suspicious nodes, indicates a high nodal burden in our population, and duration of symptoms was more than 6 months. This is an example of a random patient from the group, in which you can see that there is this lymph node which is looking suspicious, and this was biopsied and clipped. This is a patient which was ER positive, PR and HER2 negative, and this came positive on biopsy. And post NACT, it is completely normalized. And when we saw, there was no metastasis in the ALND. So that means this is a kind of a patient in whom only SLNB and clip node removal would have saved her from a complete axillary dissection. And the histology was such. So while localization was performed successfully in 26 out of 27 patients, so it was a good success rate, and intraoperative ultrasound was used in 1. Removal of clip node was confirmed always on gross dissection. SLNB was performed in 29 patients, but we had a lower than usual rate of identification, 62%, which I believe either is because of the fibrosis within the nodes or also because of the technique in which we could not use a radioactive tracer in these patients. The clip node was identified as sentinel node in 72% cases. In 28%, clip node was not the sentinel node. ALND was performed in all patients, and we saw a complete pathological nodal response in 34% of the patients. Then we divided the cohort into 2 groups of patients which had less than 2 suspicious nodes and more than 2 suspicious nodes, and we saw that the PCR of axilla is significantly higher in patients with less than 2 suspicious nodes, which was 10 in our series. Out of that, 7 had complete response after NACT. And chemotherapy related fibrosis was also very common. So the diagnostic accuracy of ultrasound after NACT was quite high, mainly because we were seeing the same node serially after each cycle. So the response was well seen. We had a sensitivity of 95.2% with a moderate specificity of 72%. And you can see here that only SLNB had a high FNR of 18.2%. But if you use SLNB and clip node, it went down below 10%. So it became 9% in our series. So the pathological complete nodal response in our study was similar to prior studies. And so we assume that ALND could have been avoided in this large proportion of patients with the use of targeted axillary dissection. Patients with less than 2 suspicious nodes on pre-NACT ultrasound are the ones that tend to gain with this technique because they have a higher complete response rate of 70%, and this subset of patients would benefit from placement in nodes and their preoperative localization. So to conclude, I would say that post NACT, there is definitely a good chance for us to try a targeted axillary dissection, provided we choose our patients carefully. The patients should be the ones with less nodal burden, that is, less than 2 suspicious nodes on pre-NACT ultrasound, and post NACT axillary ultrasound and clip node evaluation has a high diagnostic accuracy. It's very easily done procedure, and addition of clip node can definitely reduce the FNR of SLNB. Thank you.
Thank you, ma'am, for such a wonderful talk. And please, we'll request you to stay with us for the panel discussion as well. So now we will move on to the next talk. I would like to invite Dr. Gaurav Agarwal. It's a proud privilege to have Dr. Gaurav Agarwal, who is a head and professor of breast and endocrine surgery at SGPGI Lucknow. He's going to talk on de-escalation of axillary surgery after neoadjuvant chemotherapy. Is it ready for prime time? Over to you, Dr. Gaurav.
Thank you, Dr. Vaishali. Am I audible?
Yes, sir.
Thank you. So if I may start my screen share. Yeah, here I am. Okay. Firstly, it is such a pleasure for me to be speaking today. And I wish to thank both Dr. Vaishali Zamre and Dr. Goyal for this kind invitation. What I've been asked to do is to talk about um, whether de-escalation of axillary surgery is appropriate. Is it ready for prime time? Well, a lot of what I'm going to speak has quite well been introduced to or has been discussed by Dr. Smriti Hari. It is so important to have a good preoperative radiological study to be aware of what could be the probability of having metastatic disease in the axilla. And then that all those things fortunately have been covered by the previous talk. I will have to talk mostly on what is the current philosophy of breast cancer surgery. So we all agree today that contemporary breast surgery is all about doing the minimum essential surgical treatment, and less is indeed more. And this is true for the breast as well as for the axilla. So if I have to answer this question that has been posed to me, that is de-escalation of axillary surgery following neoadjuvant chemotherapy, is it ready for prime time? My answer will have to be yes, it is, but it is equally no, because there are certain situations where perhaps we can do away with the more radical contemporary axillary lymph node dissection, but in certain conditions, certain situations, we cannot. We will have to consider doing the conventional full axillary surgery. Why are we talking about this whole issue today? A lot of patients now, a higher proportion or rather increasing proportion of breast cancer patients are now treated with neoadjuvant systemic treatment. This may be chemotherapy, it may be a combination of chemotherapy and targeted or anti-HER2 therapy, and in small proportion of patients, it may be neoadjuvant hormone treatment. But if we consider or we concentrate mostly on the more effective and quickly effective strategies of neoadjuvant chemotherapy and neoadjuvant trastuzumab therapy or anti-HER2 therapy, we are using it more and more even in early stage cancers. Until some time ago, we would mostly use it for locally advanced or even large operable cancers. And we know that certain subtypes of cancers, such as triple negative and HER2 enriched, are the ones which benefit most with the neoadjuvant systemic therapy options. Pathological complete response has become a new goal of treatment. We all keep chasing it. We know it has some prognostic importance, especially in triple negative cancer patients. And we currently believe that following neoadjuvant chemotherapy, surgical treatment is to some extent lesser, it's more kinder to the patient, and is more effective in control of the local and regional disease. So, surgery of the axilla continues to be of importance both for achieving loco-regional control as well as to provide the vital prognostic information in staging. It is relevant when it is done before any other treatment, or in other words, as the primary treatment, or following some sort of neoadjuvant systemic treatment, because the index stage provides the staging and prognostic information, and so does the post neoadjuvant systemic treatment staging, because in case there is residual disease, we know these patients benefit, or this is predictive of more benefit from further treatment. So, coming specifically to this issue of discussion today, post neoadjuvant surgery of the axilla, it is entirely dependent on both the nodal stage of the axilla, or the CN stage, as well as the post NSCT or the YCN stage. It also should depend and does depend on the index tumor stage, and I will elaborate what I mean by that. So today we are discussing essentially surgical treatment following neoadjuvant systemic treatment. By and large, in the Western literature, this is today being discussed for early stage cancers, but in our scenario, in India and other developing countries, we will need to continue to discuss more in context of locally advanced and large operable cancers. So, the conventional gold standard for axillary surgery following neoadjuvant systemic treatment is a full axillary lymph nodal dissection, which is where you would dissect out levels 1, 2. Perhaps you can reduce it to omit the level 3 dissection, and which can be reserved only for patients who have significant disease in the level 3 or bulky disease in level 2. The possible de-escalation options which exist for these patients is to perform a sentinel lymph node biopsy following neoadjuvant systemic treatment if the patient has achieved a YCN0, or if the patient was as index stage was N0 to begin with, and has remained N0 after neoadjuvant systemic treatment. One can do sentinel lymph node biopsy and reserve axillary lymph nodal dissection only if we find residual metastatic disease in the axilla. There are other options, as Dr. Smriti Hari told us about the targeted axillary dissection, which is at times also called the focused axillary dissection. And this is an option in patients who have as index stage N1 or worse disease, where you can target that particular lymph node, clip it, and then remove that particular node along with the sentinel lymph nodes and the palpable nodes. Another option is low axillary sampling, which has been brought in discussion recently by our colleagues from Tata Hospital in Bombay, and we will discuss a little bit about that as well. So this whole discussion today is about, is de-escalation of axillary surgery after neoadjuvant systemic treatment appropriate? And I would like to answer this by answering two questions. Is sentinel lymph node biopsy appropriate in post NSCT N0 axilla? And is avoidance of axillary lymph nodal dissection wise in patients who have undergone neoadjuvant systemic treatment? So, answering the first question, or the rather more important of the two questions first, is sentinel lymph node biopsy appropriate for post NSCT N0 axilla? This issue is unfortunately not as well studied and or as well established as primary sentinel lymph node biopsy in early breast cancers. The available options in a patient who comes with N0 disease and is planned to undergo neoadjuvant systemic treatment is either to do primary sentinel lymph node biopsy to arrive at the definitive staging of the axilla before the NSCT is started, or we complete the neoadjuvant systemic treatment and then document the post treatment in order to document the post treatment nodal status. We do the post NSCT sentinel lymph node biopsy. The limitations of sentinel lymph node biopsy after neoadjuvant systemic treatment are quite a few. But even the pre-NACT sentinel lymph node biopsy is not a very ideal thing to do, because it negates the advantages of downstaging of the nodal disease with the neoadjuvant chemotherapy. And that is to say that a larger proportion of patients would undergo axillary lymph nodal dissection if we did pre-NACT sentinel lymph node biopsy. All those who would achieve YCN0 stage following neoadjuvant chemotherapy will undergo unnecessary axillary dissection. So, all in all, the optimal strategy for post NACT sentinel lymph node biopsy is still evolving. What are the complexities of post NACT sentinel lymph node biopsy? I'm certain this audience is quite well initiated in breast surgery, and most of you know that the concept of sentinel lymph node biopsy relies on the orderly pattern of the lymphatic drainage from a lymphatic basin. If a tumor is existing in a particular location, we know that there would be a lymphatic which will take these tumor cells to the first draining lymph node through its afferent lymphatic, and then only if there are there are number of cancer cells, they would go into the second level and third level lymph nodes. However, uh, in patients who have received neoadjuvant chemotherapy, there is possibility of fibrosis of these lymphatics, and the afferent lymphatics of the sentinel lymph nodes may become fibrosed and obliterated, and so there may be higher chances of skip metastasis, which is to say that instead of the metastasis being harbored by the sentinel node or the first draining set of nodes, the metastasis may actually be harbored even firstly or at the time of surgery in the second or third echelon nodes. So these make sentinel lymph node biopsy following neoadjuvant chemotherapy less reliable. And then the accuracy of sentinel lymph node biopsy is now very well believed to be lesser as compared to primary sentinel lymph node biopsy. And the false negative rate, which is a key determinant of quality of sentinel lymph node biopsy and reliability of sentinel lymph node biopsy in overall staging of the axilla, the false negative rates are much higher in patients who have undergone neoadjuvant chemotherapy compared to patients who have not undergone sentinel lymph node have not undergone the neoadjuvant chemotherapy. And I must caution the audience that the data that we mostly hear or read in the Western literature is mostly pertaining to patients with early stage cancers. And these are patients with limited disease burden. And this must not be extrapolated to locally advanced cancers or very large operable cancers, the kind that we often treat, and then who would undergo neoadjuvant systemic treatment followed by post NACT surgery. Why should we even bother to, if the sentinel lymph node biopsy after neoadjuvant chemotherapy is not reliable, not sufficiently reliable? Why should we be bothered about sentinel lymph node biopsy following neoadjuvant chemotherapy? It's because that increasing proportion of breast cancer patients are being treated with neoadjuvant systemic treatment, and more so for us, for Indian patients, where still a large proportion, perhaps close to 50% of all patients, present with a large or locally advanced cancer, who would require neoadjuvant chemotherapy. Unless we are aware of even these kind of strategies, we will not be able to offer them the benefit of de-escalation or lesser surgery such as sentinel lymph node biopsy. And then that, I feel, is the reason why we should be discussing this issue. Today, with use of highly effective targeted therapies in certain patient subgroups, the post-neoadjuvant systemic treatment axillary pathological complete response rates can range up to 60%. The ballpark figure for post-NACT PCR in the axilla is about 38%, as Dr. Skruti Hari also alluded to. Uh, in about a third of all patients of locally advanced and large operable cancers following NACT, we know the patients would be node negative, who were node positive to begin with. And these are all potential patients who can be spared of axillary lymph node dissection if we could do the sentinel lymph node biopsy in these patients. These are this is the data, or this is the set of data on axillary nodal downstaging with the neoadjuvant systemic treatment in 4 of the major trials: the NSBP D18 trial with use of AC chemotherapy. 30% of patients who were node positive could be rendered node negative. In the EORTC trial with use of FEC combination chemotherapy, 19% patients were reverted from N plus to N minus. Similarly, in ECTO trial, 37%, and NSBP B27 trial, 43% of patients were rendered node negative, while they were to begin with node positive. So this is to tell you that a significant proportion of patients can potentially benefit by post NACT sentinel lymph node biopsy. Now, what is the current scenario? What is the current status? There have been a number of trials, prospective, some randomized, some observational, but sufficiently high quality, which have studied this issue of post-NACT sentinel lymph node biopsy in patients with biopsy-proven N1 or N2 axilla. And these include the Sentina trial, which is a prospective multicenter cohort study, the ECOSOC Z1071, which is also called the Alliance clinical trial, yet again a prospective clinical trial for patients who have received neoadjuvant chemotherapy for and positive nodal positive breast cancers. The SNFNAC study, which is again a multicenter Canadian study, North American study, where sentinel lymph node biopsy was performed after NACT in biopsy-proven node-positive breast cancer patients, and the Genia 1 and Genia 2 French multicenter trials. These are some of those trials. And sorry, I must also point out that when we talk of sentinel lymph node biopsy, the target that we wish to achieve is to identify the sentinel lymph node in at least 90% of cases where we are doing it, and the false negative rates must be kept below 10%. That was the kind of yardstick created in the initial trials, and it does really seem logical that if unless the false negative rates, and which is a reflection of accuracy of the whole strategy, unless the false negative rates are low enough, it doesn't make sense to do sentinel lymph node biopsy or anything which is not accurate enough. So these 4 trials that I talked about, both all of these were prospective multi-institutional trials. Primarily, they included T1 to T3 cancers with N1 disease, and all of them they did sentinel lymph node biopsy followed by backup or completion axillary lymph node dissection, or validation sentinel lymph node biopsies, in other words. And these are most all fairly large trials. You can see the number of patients here, and the patients who had these are the initial stages in various studies. Most of them, as I said earlier, included only T0 to T3 cancers, but a few of the patients in Z1071 trial, less than 10% were T4, and some of them included both N1 and N2 cases, but the Genia 2 study included only strictly N1 disease. The identification rate of the sentinel lymph nodes in all these 4 trials, which used a combination of radioisotope and a blue dye, they ranged from 93% in the ECOSOC Z1071 trial to as low as 80% in the Genia 2 and the Sentina trials. And more troublesome fact was that false negative rates in all these 4 trials were more than 10%, that the desired false negative rates were not achieved in any of these trials. The use of dual tracer and removal of more than or equal to 3 sentinel lymph nodes resulted in false negative rates of less than 10% in at least 2 of these trials. So these studies, this is some more data on the same studies. As I said, the sentinel lymph node identification rates were low, but just to show you that as the number of sentinel lymph nodes retrieved were higher, went up, the false negative rates could be brought down. And in the ECOSOC Z1071 trial, as well as Sentina, the third arm of the Sentina, if 3 or more nodes were removed, the false negative rate could be brought down to less than 10%. And if the dual tracer was used, definitely we could the trials could document less than 10% false negative rates. And if in case one of these trials used, or two of these trials used immunohistochemistry to identify submicrometastasis or isolated tumor cells in the central lymph nodes, and yet again with that strategy, the false negative rates could be brought down to less than 10%. These are the factors which influence the false negative rates in these trials, the number of lymph nodes removed and the tracers used. And so the strategies that can be used, which were used in these trials to remove, to improve the central lymph node identification rates and reduce false negative rates in post-NACT central lymph node biopsy, was to use dual tracers, minimum 3 nodes to be retrieved, IHC to identify the isolated tumor cells and micrometastasis, and targeted axillary dissection in patients who had CN1 disease to begin with. Another issue that is at times discussed in patients who present with CN0 disease, the index stage is N0, whether they should undergo primary sentinel lymph node biopsy or post NACT sentinel lymph node biopsy. Both are appropriate. At least some trials, Sentinel study did study the probability of using pre-NACT sentinel lymph node biopsy and follow it with post-NACT evaluation and re-biopsy, and they found that the pre-NACT sentinel lymph node status was identical, more or less identical with the post-NACT status, and so they concluded that the post pre-NACT sentinel lymph node biopsy is quite reliable, and the post NACT sentinel lymph node biopsy has somewhat lower sentinel lymph node identification rate and higher false negative rate. Uh, Dr. Smriti Hari talked about the focused or the targeted axillary dissection. It was initially initiated in the at the ND Anderson Center and Cancer Center, but then over the last 3-4 years, there have been number of studies and reports of use of focused or targeted axillary dissection. What is its role? Its role is entirely limited to patients who have CN1 disease, who have been planned to receive neoadjuvant systemic treatment. And as has been explained in the previous talk, before initiation of NACT, the patients undergo a ultrasound guided core biopsy from the lymph nodes, which is most likely to be metastatic, and then a radio opaque clip is put into that particular lymph node. There are alternatives which can be used, such as carbon tattooing, putting in a radioisotope seed, or super magnetic iron oxide seeds. And then, after completion of neoadjuvant chemotherapy, if the patient has become N0, then you can do, besides the sentinel lymph node biopsy, also a targeted removal of those clip nodes by putting in a wire hook or other ways, as Dr. Smriti Hari explained. And this has been shown to reduce the false negative rates of sentinel lymph node biopsy by half, and the local recurrence rates or local regional recurrence rates too have been reported to be reduced by doing this kind of targeted axillary dissection. But this is a strategy which is still under evaluation and more trials are underway. So the current take that I can give you for as far as this strategy of post NACT sentinel lymph node biopsy is concerned, that it can be considered for patients who have index stages of T0 to T3 breast cancers, not for T4 cancers, and I will elaborate more on that a little later. It is definitely applicable if the patient was to begin with CN0 and no worse than T3, and its role for managing patients with CN1 is somewhat more controversial, and definitely very controversial if the patients had matted lymph nodes or N2 disease to begin with. In such scenario, targeted axillary dissection is helpful. If it if we have retrieved 3 or more sentinel lymph nodes and we are using IHC for isolating for identifying isolated tumor cells, then perhaps it is appropriate. It is definitely not standard of care for patients who present with CN2 or worse disease, and more studies are required. Having done a sentinel lymph node biopsy, how do you address the axilla if there is any metastatic central lymph node. In primary setting, I'm certain most of you would be aware, we know that for low risk cancers, early stage, hormone responsive patients who are going to undergo whole breast radiation, if there is one or two metastatic central lymph node, you can perhaps avoid a completion axillary dissection. But in post NACT central lymph node biopsy strategy, there is no scope for avoidance of axillary dissection if one has found even a single sentinel node which has harbored metastasis. Even if there is micrometastatic disease or isolated tumor cells, one must completely dissect the axilla because avoidance of axillary dissection in this scenario has not been studied so far in any of the clinical trials. So, is routine level 3 dissection needed? Uh, this is an ongoing debate, perhaps only in our country and perhaps a few other countries where we know that the nodal burden of disease in the axilla is quite high, and we continue to debate whether level 3 should be dissected routinely. But going by the overall consensus globally, it seems more appropriate to reserve level 3 dissection only for patients who have high nodal burden otherwise, because level 3 dissection adds to the risk of lymphedema and brachial plexus injury. It is recommended in patients who have grossly involved level 2 or level 3 nodes. There is, if however there is low risk, low burden of disease in the axilla, routine dissection or level 3 dissection is not recommended. Now, coming to another important issue, and that is whether sentinel lymph node biopsy is an option in patients who have locally advanced cancers or large operable cancers, and then they have undergone neoadjuvant chemotherapy. There is very limited data in the prospective studies. The four trials that I talked about, the Sentinel and the Alliance trials, had 5% LABC and 25% LOBC cases. So by and large, these were predominantly early breast cancer patients, and so their data, their results cannot be extrapolated to locally advanced cancers. This has been an area of research interest for me and my colleagues in SCPGI. We initially presented our results in the San Antonio Breast Cancer Symposium in 2015, and subsequently in 2016 published our results of a prospective comparative validation study. This was published in World Journal of Surgery, where we compared the sentinel lymph node biopsy results in stage 3 cancers, large operable or locally advanced cancers who underwent either a primary sentinel lymph node biopsy or a post NACT sentinel lymph node biopsy if the patient had N0 disease. So this was a prospective non-randomized study. Total of 120 patients were included, and we excluded any multifocal, inflammatory, ulcerated, or any cases who were and not N0 at the time of surgery. The group 1 consisted of patients, 50 patients with T3 or T4 disease, but with N0 as primary stage, and who underwent a primary surgery. And majority of these patients were T3 N0 cases who underwent modified radical mastectomy or could have undergone modified radical mastectomy, but we performed sentinel lymph node biopsy and axillary dissection as validation procedure. The group 2 had 70 patients with T3 or T4 disease with N1 or N2 stage disease to begin with, and then following neoadjuvant chemotherapy, they were rendered YC N0. And we did their sentinel lymph node biopsy post NACT, and we compared the sentinel lymph node identification rates and the false negative rates between the two groups, so to study whether pre-NACT sentinel lymph node biopsy is more accurate or post-NACT is equally accurate. These are the results. In the group 1, which is primary sentinel lymph node biopsies, 91%, we could identify the sentinel lymph node in 94% patients, whereas in the post-NACT overall, the sentinel lymph node identification rates were dismal, only at about 83%. However, we must not overlook the fact that the primary sentinel lymph node biopsy was done predominantly for T3 disease, and if we restrict the post NACT sentinel lymph node biopsy identification rate to T3N0 or T3N1 index stage, the identification rates were not so different. they were equally good as they were with primary sentinel lymph node biopsy. Similarly, for locally advanced cancers, T4B disease, irrespective whether the sentinel lymph node biopsy was done pre-chemotherapy or post-chemotherapy, the identification rates were low. So these are results which tell us that our infiltration of the skin, and so the infiltration of skin and subcutaneous lymphatics, that results in poorer sentinel lymph node identification rates, and is perhaps not worthwhile doing sentinel lymph node biopsy in patients who have locally advanced cancers. Now, looking at the sentinel lymph node false negative rates. Again, group 1, which was primary sentinel lymph node biopsy, the false negative rates were 7.7%, quite acceptable. But don't miss out the fact that majority of these patients were T3 disease, and the false negative rates were quite low. But the T4B cases had a very high false negative rate, unacceptably high false negative rate. Now, post NACT, the overall cohort of post NACT sentinel lymph node biopsies, the false negative rate was unacceptably high at 13.5%. But in patients, the few patients of T3, N0, or N1 disease who underwent post NACT sentinel lymph node biopsy, they did not have any false negative results. And which means that these patients who have adverse T3 disease and adverse N1 disease, even after NACT, the sentinel lymph node biopsy is quite accurate. But patients who had T4B disease or N2A disease, or a combination of both, these patients had worse than 10% false negative rates. And these are the kind of patients we would not advocate doing sentinel lymph node biopsies. Uh, Having looked at the various subgroups in patients who underwent post NACT sentinel lymph node biopsy, what were the factors predicting unidentified sentinel lymph node and false negative sentinel lymph node biopsy? Young age, tumor stages T4B, nodal stages of N2A or worse, lymphovascular invasion, and extranodal spread. All of these are predicted that we would not be able to identify the sentinel lymph node, and the sentinel lymph node we identify may not be the most reflective, and there may be a false negative result. So, from our prospective study, though it's not a randomized study, but we concluded the sentinel lymph node biopsies have a limited role in staging axilla of stage 3 cancers. Accuracy of sentinel lymph node in T3 and 0 tumors is comparable to early breast cancers. It's not different whether it is done as a primary strategy or post NSCT strategy, but we must not avoid axillary dissection if there's even a single metastatic sentinel lymph node. In post NSCT patients with T4B or N2A disease, sentinel lymph node identification rates are low and false negative rates are high, and so axillary lymph node dissection should be carried out in all these patients who have undergone neoadjuvant chemotherapy. Now, this was all about sentinel lymph node biopsy in locally advanced cancers. But an alternative strategy of low axillary sampling has been propagated by our friends from Tata Hospital, and this paper is absolutely fresh off the press. This was published just about 10 days ago in the JCO Global Oncology, where Vani and others from TMH, they compared the efficacy, the identification rate and false negative rates of sentinel lymph node biopsy with low axillary sampling for predicting nodal status of post NACT axilla in women with breast cancer. There are a few kind of discrepancies or shortcomings in this paper as I went through the full text, which I haven't had the chance to discuss with the friends in TMH. But nonetheless, this is the study design. They included 790 eligible women. In the methodology, they have noted that they've not categorically said whether these were all stage 3 cancers, but uh, it appears that there were a number of patients who had early stage cancers. They excluded some of the patients for various reasons as listed here, and so that left them with a cohort of 751 eligible patients. All these patients first underwent low axillary sampling, which they have defined as excision of all the fibrofatty lymphatic tissue and lymph nodes inferior to the first intercostal nerve. And then simultaneously, the patients underwent central lymph node biopsy and completion axillary dissection. These are the results. I will not go into too many details for the want of time, but they concluded that the low axillary sampling in their hands was superior to central lymph node biopsy in identification rates, in terms of identification rates, false negative rates, and negative predictive value in predicting node negative axilla following NACT. And they say that it can be safely used to predict negative axilla with less than 10% chance of leaving residual disease in carefully selected patients. And I think the most important part of their conclusion is that they feel that the long-term follow-up data on safety of axillary conservation, in other words, de-escalation post NACT in LABC patients is needed. Until such time, complete axillary surgery must be done in most of these patients. So uh, coming to the conclusion, the post NACT evaluation of central lymph nodes is currently still a strategy under evaluation, or which is still evolving. The various guidelines they talk about possibility of use of central lymph node biopsy, but these set of guidelines have projected just to highlight the fact that the sentinel lymph node biopsy following NACT remains a category 2B, or rather weak recommendation, and not necessarily a very high quality recommendation. To summarize my talk, post NACT management of axillary lymph nodes continues to be an essential part of the treatment of breast cancer patients. ALND remains the standard of care for majority, but pre-NACT sentinel lymph node or post-NACT sentinel lymph node biopsy is an option in selected group of patients, which are T0 to T3 to begin with, and N0 to N1 adverse to begin with, and definitely not for T4 or N2 or worse kind of patients. The post NACT sentinel lymph node biopsy, the identification rates are low and false negative rates are higher compared to primary sentinel lymph node biopsy. These can be improved by use of dual tracer techniques, by retrieving 3 or more lymph nodes, and by use of immunohistochemistry for identification of isolated tumor cells, and by incorporating targeted axillary sampling or dissection in patients who had N1 disease to begin with. LND is a must, or complete axillary dissection is a must in patients where sentinel lymph nodes have been identified with even a single metastatic node. The radiotherapy decisions must be based on the pre-NACT staging and not on the post-NACT staging. And I leave you with this kind of a summary of management of post-NACT axilla in patients who have CN0, the index stage of CN0, and continue to be N0 after neoadjuvant chemotherapy, or YCN0. The options that you could have done a pre-NACT sentinel node biopsy, but you can equally do post-NACT sentinel lymph node biopsy. If the sentinel lymph node harbors a metastasis, you must do a complete axillary dissection, even if there's a single metastatic node. And post-surgically, adjuvant RT is reserved for patients who have PN1 or worse disease, if the patient has undergone a mastectomy. If the patient had an index stage of CN1 and following neoadjuvant chemotherapy, the patient has now become N0, then you have an option of sentinel lymph node biopsy or focused axillary dissection or targeted axillary dissection, followed by ALND if there is a metastatic node, and adjuvant RT. If the patient had CN1 disease and continues to be N1 following NACT, patient must undergo axillary dissection, and the same is true for CN2 and 3 disease. Irrespective what the stage of disease is following NACT, patient should undergo axillary dissection. Patients who have CT4 LABC or inflammatory cancer, irrespective of the index nodal stages, irrespective of post NACT stages, I feel the patient should undergo full axillary dissection and adjuvant RT. So, de-escalation of axillary surgery post NACT, is it ready for prime time? I think it is the answer is yes and no. Yes, for patients who had T1 to T3 and N0 to N1 disease to begin with, and no for patients who had T4 or N2 or N3 to begin with. Thank you very much.
Thank you, Dr. Gaurav. That was a marvelous presentation, I would say. And I'm sure all the audience and the other faculty members also would agree to me. Now, after this wonderful presentation, we will move on to Dr. Ramesh Sareen. Ma'am actually needs no introduction. Nonetheless, I would do that. She is one of the most senior breast cancer surgeons in our country. She has been working in Apollo Hospital currently, and we would like to hear her experience of doing sentinel node biopsy after neoadjuvant chemotherapy. Over to you, ma'am.
Thank you, Vaishali, for asking me to be a part of your ongoing focus studies in breast cancer. Maybe Arun Goyal can present my slides. But let's take a deep breath. We had such an exhaustive session from both, wonderful session from both Smriti and Dr. Gaurav. And I think there is not much to learn, but I will still present you our experiences at the Apollo Hospital. Can I have the next slide, please? Some of the first 3-4 slides may be a repetition of what Dr. Gaurav and Dr. Smriti has said, but it's important for me to re-emphasize this. So we all know that neoadjuvant chemotherapy has become the standard of care, is the standard of care for inoperable locally advanced breast cancer. But neoadjuvant chemotherapy is being increasingly used for operable breast cancer, both for downstaging the breast tumor and the axillary lymph nodes. And I think at this point of time, we should not be operating with any patient having a level 3 disease in the axilla. All of them should go for a neoadjuvant chemotherapy. And as you will see that 50 to 60% of them can be downstaged. So at this point, I don't think we should really attempt to do primary surgery for patients having N2 and N3 disease. National Surgical Adjuvant Breast Project B18 was the first trial to show that neoadjuvant chemotherapy increases the breast conservation rates, but optimal surgery for axilla was not defined. The next slide. So the advantages of neoadjuvant chemotherapy, as you already heard, are many in operable breast cancer, because the neoadjuvant chemotherapy gives us the opportunity to evaluate the efficacy of chemotherapy on the primary tumor and the lymph nodes. Is the chemotherapy working or not working? And I think if the chemotherapy is not working, the medical oncologist should change the chemotherapy. It also gives us the opportunity to do limited surgery in breast and axilla. And the neoadjuvant chemotherapy, as you already heard, gives us the prognosis. And now we know that if there is a residual tumor, you can do something about that with the CREATE-X and the Catherine trials in HER2 positive disease. So I think it's all the more important that neoadjuvant chemotherapy gives us the opportunity to add another line of chemotherapy if a patient is not responding. Again, as we all know, that pathological complete response in the breast and in the axilla is a surrogate marker. 80 to 90% of the people who have PCR in the breast and axilla will have a normal life except for the brain. And it's also a very good way for a faster way for the newer drug development. So there are many advantages of doing neoadjuvant chemotherapy even in operable breast cancer. The next one. So just another 1 or 2 slides before I come to my data. The optimal axillary surgery in patients with neoadjuvant chemotherapy who convert to CN0, the latest NCCN guidelines you have already been told, and this is that if it is a clinically negative axilla before the neoadjuvant chemotherapy, sentinel lymph node is a safe procedure, provided CN0, provided CN0 is both clinically and radiologically negative on ultrasound and ultrasound guided FNSC if required, plus minus MRI. So I'm emphasizing that selection of CN0 patient is important pre-neoadjuvant chemotherapy and post-neoadjuvant chemotherapy. In patients with positive axillary lymph nodes prior to neoadjuvant chemotherapy, the standard, as you heard, has been the axillary lymph node dissection, and that's what we are going to discuss now. Next one. We all know that when the neoadjuvant chemotherapy has been given, 76.4% of the patients with hormone receptor positive, HER2 negative, could avoid axillary lymph node. As we said that already, if it is CN0 or CN1, 86% of the patients with triple negative subtype could also avoid axillary lymph node dissection. And this, I'm talking of clinically node negative patient. Those seven, if you do the sentinel lymph node before the surgery, there is 75% of them do not have it, but after you give them chemotherapy, almost 86.1% of the triple negative and 87.1% of the hormone receptor positive subtype in clinically node negative patient do not require axillary lymph node dissection. So if these patients do take neoadjuvant chemotherapy, then it's mandatory that we should do a sentinel lymph node biopsy. The next one. Coming to the, as Dr. Gaurav has repeatedly emphasized, and I am re-emphasizing, that unlike the sentinel lymph node biopsy without neoadjuvant chemotherapy, axilla may not be dissected if it is one or two positive lymph nodes, especially Z0011 and Amaros trial. But in patients after neoadjuvant chemotherapy, even if one node is positive, axillary dissection is a must. So it's again being re-emphasized that one lymph node or micromets, depending on the radiation studies that may come up later on, but at this point of time, axillary lymph node dissection is the order of the day. So those who can convert patients who convert from CN1 to CN0, sentinel lymph node is recommended. This is the literature. This is the scientific literature that you already heard. I'm just emphasizing last study before my own data. Sentinel lymph node biopsy is recommended if PET negative after neoadjuvant chemotherapy. How do you decide which patient who had CN1 disease before the neoadjuvant chemotherapy should undergo sentinel lymph node or not? So you have to be sure that this patient has converted to CN0. So how do you find out this is converted to CN0? Is either you do a PET CT, and as I will show from our own data, we rely more on ultrasound, as Dr. Smriti has said, by a dedicated ultrasonologist, and or MRI. Something happened. So the false negative rate, as we already heard in the literature, is 9.1% when 3 or more than 3 lymph nodes with a dual mapping is done. False negative rate drops to 8.4% if you add immunohistochemistry to the sentinel node. And clips can be placed. This is what the literature says, but our data is a little contrary to all this. Coming to the next slide. So the recommendation, I think I'll leave that. It's already been talked about by Dr. Gaurav Agarwal. The next one, coming to my own data, we had operated on 118 patients, which included both operable and locally advanced breast cancer who underwent neoadjuvant chemotherapy. whether they were CN0 or CN1. I'll come back to that. This is from 2011 to 2019. And this slide is indicating that the number of patients who have been recruited into the neoadjuvant chemotherapy has increased from 2015 onwards in an exponential manner. A large number of patients are now being put into neoadjuvant chemotherapy, and this involves the patients who are early breast cancers, even with CN0 or CN1. The next one. This again shows you the primary tumor size and the year of recruitment, and that is that this one is the T4 lesions. This is the T4 lesions. The T4 lesions and the T1 to T3 lesions were equal in number in the beginning, but now T4 lesions have come down in the come down in the recruitment, and larger number of patients are being recruited in T1 to T3 patients are being recruited for neoadjuvant chemotherapy, because we now know that the response rate of triple negative and HER2 positive disease is tremendous, both in the breast and in the axillary lymph nodes. The next slide. This one, we divided the era into two: 2011 to 2015 and 2016 to 2019. And as you can see, the T1 to T3 patients, equal number of patients were in the era 1 and same number in era 2. I mean, larger number of patients are being recruited when neoadjuvant chemotherapy of T1 to T3, and T4 lesions, the lesser number of T4 lesions. It is possibly we are also getting less locally advanced breast cancer because of the urban area and more of awareness. Even the end stage disease, in the era 1, only 23% of the patients were in N0, and now and N1, there were lots of patients in this era in N1 disease, and now a larger number is N0 patients with neoadjuvant chemotherapy. So more and more of neoadjuvant chemotherapy is being given in patients who are early stage as well as N0. Next one. This is just the two slides, the type of surgery of the primary tumor. Initially in era 1, after neoadjuvant chemotherapy, only 15.4% of the patient could undergo breast conservative surgery. Now with oncoplasty and better response rate with better chemotherapy, almost 40% of the patients are having breast conservative surgery. Those who have undergone neoadjuvant chemotherapy, it's like half of them are having breast conservative surgery, as against only 15% in the previous era. Next one. It's not because a large number of T1 to T3 are being recruited and that's why they are having breast conservative surgery, but you can see that breast conservative surgery initially in 2011 to 15 was 25%, and now it's 42.6%. And the breast conservative surgery, this is T1 to T3, and in T4 disease also, I do not know why. In T4 disease also, we are able to do breast conservative surgery in 38.9% of the patients. So it depends on the response rate, and then depends on the biology of the tumor. If the response is complete clinically, radiologically, then doing breast conservative surgery, I think, does no harm in these patients. The next one. The nodal PCR in the end stage, you can see that the the pathological complete response rate in N0 patient, I'm talking of pathological complete response, was in 60.9% of the patients. Somehow it should be higher, but this is what we have. It is possible that earlier on we were not very choosy about putting patients in N0 because we were not doing guided ultrasound of the axilla and or MRI. But however, 65% of the patients had pathological complete response in N0, and 51% of the patient had pathological complete response in N1. So in N1 also 50% of the patients had. So if we are able to pick up these patients properly, they could avoid axillary lymph node and its mobility. The next one. This is in 118 patients. And if you can see the molecular subtype, if you see that this group is the hormone receptor positive, the response rate of the primary tumor is only 25.7%, while the response rate in the HER2 positive disease is 47.6%, while the response rate is 46.3%. And this red one is in the breast tumor in the T stage, while the nodal stage has a higher response rate and much higher response rate if you are triple negative or HER2 positive. So you could see, and I allude to this is higher than what the literature is saying. I allude to this by the fact that recently our medical oncologists are giving full dosages. The patients are getting dose dense chemotherapy and they are getting it online with all the support and everything else. So even the first dose, I don't let them reduce. The first dose of chemotherapy is also full dose, and majority of the patients being in the urban area are getting either Herceptin plus minus pertuzumab in HER2 positive disease. The next one. This one, I just made a slide saying that because there was a trial at the MD Anderson saying that if you have a PCR both in the breast and in the axilla, you don't need to do surgery in the breast. You can only do the axillary sentinel lymph node and leave it there. So the nodal PCR and the breast PCR, both things happen in 35% of the patients. So these patients could have a VAB of the breast and the sentinel lymph node, and if you find it negative, I suppose I'll tell you how we leave it behind. Nodal PCR and not breast PCR was, as I said, nodal PCR is much higher than the breast PCR. So 22% of the patient had a nodal PCR, but not the breast PCR. Come back to this, where there is no response, there is no complete pathological response in the breast and the axilla in 37% of the patients. So 37% of the patients do not respond to the chemotherapy, whatever chemotherapy you give. The next one is now coming to the center. Next slide, please. A sentinel lymph node post neoadjuvant chemotherapy. Now, all our patients who were CN0 initially, as I said, clinically CN0, and those who converted from CN plus to CN0, who took chemotherapy, converted to CN0, were based on guided ultrasound. And there is one ultrasoundologist who does all this, and he does the ultrasound just as Dr. Smriti has mentioned. For the axilla, and high quality contrast enhanced MRI is done in all patients pre-neoadjuvant chemotherapy and post-neoadjuvant chemotherapy. We feel spending 10 to 18,000 rupees for a high quality contrast MRI is worth the effort as against the chemotherapy, which costs about 4 lakhs every 3 weeks if you're HER2 positive. So this is done before and after. Axillary sampling like the FNSC is done wherever it's needed, and all patients underwent sentinel lymph node plus minus low axillary sampling. I'll tell you which patients underwent this, and axillary lymph node if needed. all patients had dual mapping, including the scintimammography. So all patients had triple mapping. The next one, out of the 118 patients, 76 patients were CN0 based on guided ultrasound and MRI. The rest of them had a tumor, residual tumor, and so they all went for axillary dissection. Out of the 76 patients where the CN0 was attained, whether initially or after neoadjuvant chemotherapy, we could recover sentinel lymph nodes in 65 patients, giving an identification rate of 86%, and the average number of sentinel node dissected in this group of neoadjuvant chemotherapy patients was 4.2. And if you come to this, as you heard from the literature and Dr. Gaurav's lecture, saying that when the patient is T1, T3, and 0, the identification rate was 100%. And when the patient was T4, N1, or N2, we did not differentiate between N1 and N2. The identification rate was the lowest, while it was in between the other groups. So obviously T1, T3, N0 identification rate is akin to if you do sentinel node before neoadjuvant chemotherapy. See, we only do sentinel lymph node after neoadjuvant chemotherapy if a patient is going to receive a neoadjuvant chemotherapy. So this is according to the this is given in the graphical form, the same thing that I've talked about. The next one, so out of this sentinel lymph node dissected, what was the false negative rate? The overall false negative rate, I'm counting both CN0 per primum and CN0 who converted from CN1 to CN0. The false negative rate was 9.1%. And if you come to this slide first, the false negative rate in patients who were N0 and received neoadjuvant chemotherapy before neoadjuvant chemotherapy, N0, was 9.1%. 33 patients underwent sentinel lymph node. In 31, we were able to dissect the sentinel lymph node, and it was sentinel lymph node was negative in 22 and it was positive in 2, giving a percentage of 9.1%. In N1 disease, which converted to CN0, we had 43 patients and 34 we could identify the lymph nodes. They were negative in 22 and the false negative rate was also 9.1%. If you come to this slide, according to the number of lymph nodes dissected, if the lymph node dissection were 3 or more than 3, the false negative rate was only 3%. So alluding to the fact that this is an important factor. If the sentinel lymph node was 1, why was it 1 in some of the earlier series? The false negative rate was 30%. So at this point of time, we would not do a sentinel lymph node where only one node is dissected. So we always attempt to do 3 or more than 3 lymph nodes, and I'll allude to the fact how do we get to that. The next one. So in our, we do, as I said, we do sampling. I'll come back to this. So we have a change of axillary management over time from 2011 to 2019 in patients undergoing neoadjuvant chemotherapy. In era 1, as I said, was the first 5 years, 2011 to 15. Their patients CN0 or C1 plus based on clinical examination and ultrasound. We were not doing MRI in those days. Neoadjuvant chemotherapy was given. Everybody received all the cycles. We were not doing mid chemotherapy surgeries. Everybody received all. And post neoadjuvant chemotherapy, again ultrasonography, and some patients had an MRI, but everybody had an axillary lymph node dissection, whether they were negative or positive, and plus minus axillary dissection. Coming to era 2, which is more important, our CN0 or CN1 plus pre-neoadjuvant chemotherapy is very dedicated based on mammography, ultrasonography, MRI, plus minus final. So we like to put patients into CN0 or CN plus before neoadjuvant chemotherapy on a very dedicated radiology and imaging studies. Patient is given neoadjuvant chemotherapy, and post neoadjuvant chemotherapy everybody undergoes ultrasonography of the axilla and MRI of the breast. You may say, why MRI of the breast? But this is we're doing this even for the T size, the tumor in the breast. So obviously we look at the lymph nodes also carefully. So post neoadjuvant chemotherapy, if patients who are CN0, either they converted to CN0, they were CN0 to start with, or they converted to CN0, we would do sentinel lymph node biopsy and try and get 3 or more than 3 axillary lymph nodes. If there are no 3 sentinel lymph nodes, we do axillary sampling. So we do allude to axillary sampling in addition to sentinel lymph nodes if they are less than 3. And obviously, as we said earlier on, even if one lymph node is positive, patient has an axillary lymph node dissection. If the axillary lymph nodes are negative, there is no axillary lymph node dissection. And we also convince our radiation oncologists not to give them external ERT if the patient is CN0, but obviously the studies are going on for this. Now, if a patient after all this post neoadjuvant chemotherapy, we said patient is node negative post NSE, but it turns out to be, go ahead. If patient continues to be CN positive, of course the patient goes for regular lymph node. Now in patients who convert from CN positive to CN0, this is the group we are discussing. After all this, I'm coming back to this group. The next slide tells you what do we do if a patient convert from CN positive to CN0, which is based on dedicated imaging. As I said, CN0 is based on dedicated imaging. We do a sentinel lymph node biopsy, plus we also do an axillary sampling and try and get 3 or more than 3, 4 or more than 4 lymph nodes. Now, if all this is negative, we do not do an axillary lymph node dissection. Also, as I said, the external radiotherapy is little debatable. Now, if a patient from this is positive, goes for an axillary lymph node dissection. Now, a large number of patients are either suspicious on imaging, like one of the images is positive, the other one is not positive. The radiologist says, I'm not sure if it's negative or positive. We don't do an FNSE post neoadjuvant chemotherapy. So this is a difficult one. And in this one, we do sentinel lymph node and level 1 axillary lymph node dissection, whether it's negative or positive. Sentinel lymph node, even if it's negative or positive, if it's negative, we do level 1 axillary lymph node dissection. Of course, if it's positive, we do this one. So targeted ultrasound and dedicated contrast enhanced MRI, clinical examination and axillary sampling, in addition to sentinel lymph node, has replaced the clipping, tattooing, and the iodine 1 to 5 seeds and targeted axillary nodes in patients who convert from CN positive to CN negative in our setting. So we are depending on the dedicated ultrasound, clinical examination, MRI, and sentinel lymph node with sampling to replace the clipping, tattooing, and the iodine 1 to 5 seeds, because we did clipping in 5 patients, in 2 we couldn't find the clip. Iodine 1 to 5 seeds are not available, and tattooing, actually you cannot do it pre-neoadjuvant chemotherapy, doing post-neoadjuvant chemotherapy, and if you put more than 2 mil, it causes problem in identifying the tumor and all that. So there are problems in all the others. So we replace that with a sampling and sentinel lymph node biopsy. The next one, so just quickly going over this one patient, I'll tell you, is a 33-year-old lady who had a 6 centimeter mass, as you can see over there, but the MRI did not show any lymph nodes, though the PET CT showed one pick up lymph node. But the MRI and the ultrasound, which I don't have it here, did not show any lymph nodes. So she went for a pre-neoadjuvant chemotherapy because she's young and she wanted a breast conservation. She was to get married and all that. Post neoadjuvant chemotherapy, the tumor was small, had reduced but not completely, and no axillary lymph nodes were there. So, what do you do in this patient? So, this patient underwent a sentinel lymph node and a sampling and this was negative, 0/3 sentinel lymph nodes. Now, because of the pre-neoadjuvant chemotherapy, we had a positive lymph node. So obviously, in a young lady, we were scared and the size was very large. So she had a level 1 axillary lymph node dissection, which was also negative. So 0 out of 15 lymph nodes in the final path. And so we are quite sure that this lady has no axillary lymph node mets. The next one. So, so from in our data, all our patients who convert to CN0 for CN1 undergo sentinel lymph node with axillary sampling, followed by level 1 or 2 axillary dissection as required. Overall, the false negative rate is low, 9.2%, and 3% if more than 3 nodes are dissected with dual mapping. We depend on clinical ultrasound and MRI to suggest if a patient has converted to CN0 post neoadjuvant chemotherapy. We think and we believe, and if these criteria are met, sentinel lymph node is a valid option in patients with CN1 converting to CN0 post neoadjuvant chemotherapy. Next one. So the last slide is our guidelines. At this time, I have all the X-rays in the OT, pre-neoadjuvant, post-neoadjuvant, ultrasound, clinical examination, MRI, everything, and then then we decide if the sentinel lymph nodes are negative, what are we going to do? So radioactive iodine seeds, as I said, is not been possible in our hospital, and it's a cumbersome procedure. And 25% of the time, the lymph nodes are not seen on initial sentinel lymph node. 91% concordance rate has been found between a negative axilla post neoadjuvant chemotherapy and combined guided ultrasound and dedicated. So wherever we found this, we also found that the lymph nodes were negative. Overall, false negative rate was low, as I said. In doubtful cases where one imaging may be positive and the other is negative, we will do a level 1 axillary dissection. And even if one sentinel lymph node is positive, as we already been pushing, do not go to Z001 trial, but proceed to axillary lymph node, unlike the 001 trial. So this is how it's a retrospective study. You could find some faults with the retrospective data, and I haven't gone into the details of how many exactly were T4 and N1 and what's happened to them. But this is what I feel is a very feasible option in our country, where the clip notes, the radioactive iodine seeds, and the tattooing seems difficult. Thank you so much for patient hearing.
Thank you, ma'am, for a very nice talk. And I must say you've done some pioneering work in this field. So one of the very few centers in India who's done work in this field. And now I would straight away invite my colleague, Dr. Vaishali Damre, to go ahead with the panel discussion. And in the panel, along with our speakers, we also have Dr. Kanchan Kaur, who's breast surgical oncologist at Medanta, Dr. Tripti Saxena, who's a radiation oncologist at Max Patparganj, and Dr. Shefali, who's a medical oncologist at Max Saket and Max Smart. Dr. Vaishali, over to you.
Yeah, thank you, sir. I once again welcome all the panelists. Although most of the discussions which I had planned in this has already been covered by Dr. Gaurav and Dr. Sareen and Dr. Smriti as well. But nevertheless, it will be wonderful to listen to other panelists as well. So as we know that in early breast cancer, the objective or the goals of a treatment are in addition to the oncologic safety, it is the quality of life which is actually take precedence when we discuss about the management plan. When we discuss about neoadjuvant chemotherapy in our country, in the current scenario, majority of the patients who are actually planned for neoadjuvant treatment are actually LABCs and LOBCs. So whether the philosophy should be different, whether de-escalation of breast primary as well as axillary treatment should be considered, all that we are going to discuss in the panel discussion. And let us move on. So as has been alluded to by the previous speakers, the 1071 and other trials like Sentina, Gania and other trials have actually shown us that in the neoadjuvant scenario, sentinel node biopsy is feasible, although the identification rates are slightly inferior and the false negative rates are definitely a little higher compared to a primary surgery scenario. So with this background, let us move on and let us hear Dr. Kanchan, this is to you. As I said, that early breast cancer, yes, we consider that quality of life is definitely an important issue. But in real LABCs, when we do neoadjuvant treatment, do you think that de-escalation is important when we know that survival is definitely inferior even after doing a complete neoadjuvant treatment? These patients who are real LABCs, they do inferiorly in terms of survival compared to early breast cancer patients. So do you think doing de-escalation surgery in axilla by doing sentinel lymph node biopsy, are we taking any risk? Or is it important to do de-escalation? What is your perspective on this?
Thank you for inviting me to be part of this very interesting series of lectures that is planned. Sorry, I've got a bit of a sore throat, but I must say we've had such an interesting evening. I feel like any doubt that I ever had about de-escalation and nodal biopsies in post-neoadjuvant chemotherapy setting have been explained so beautifully by our esteemed speakers. So, yes, de escalation is important. Yes. But what we have to understand, and as has been stressed by all speakers before me, is that just because the option of de escalation is available, we should not forget what are the basic oncological principles, which is that the oncological safety must not be compromised just because a study has been done in the West, and we are very, very eager to extrapolate it to our setting, which in most cases we cannot. So, yes, de escalation is important, but only in a very, very highly select group of patients, A. B, only in those units where a very good radiology and pathology backup is available. So, a good MDT setting is extremely important. And Vishali, over here, I do want to, just point out when on one hand you're talking about life expectancy and how, and on the other hand, we're talking of is de-escalation or doing lesser surgeries, of any use in such patients. I don't think, I don't think that should be the deciding factor. I remember I once assisted a doctor when I was just learning breast surgery in a patient who was adamant on not having a mastectomy, had metastatic disease, and post chemotherapy had come for surgery. And he did a beautiful reconstruction for her. And I couldn't understand why she was having a reconstruction when her life expectancy was only 1 year or 2 years. What we have to understand is whatever life our patient has should be with minimum morbidity, provided the procedure that you're doing for the patient is not being oncologically unsafe.
Absolutely, absolutely. This is what actually I wanted to bring out from you. So, as it has been already discussed by Dr. Gaurav Agarwal, that currently whatever data about neoadjuvant chemotherapy and sentinel node biopsy post NACT is available is in the form of either large single center studies or by meta-analysis or few, randomized trials. But in majority of these trials or studies or publications, we see that the real representation of what we see in terms of LABC is actually not done in these studies. So can this data be extrapolated and used for doing de-escalation of axillary surgery in our current scenario? Dr. Gaurav, would you like to add anything more to this, and by what more would you need to go ahead with de-escalation in especially LABC, the factors which you have actually said, that T4 and N2 disease you would not feel comfortable and you recommend that we should be doing ALND. But what else do you need to go ahead with sentinel node biopsy or de-escalation in these kind of patients as well?
Okay, so if I understood you correctly, we are talking mostly here about locally advanced cancers,
Yes, sir. Yes,
large
sir.
operable cancers. I feel if a simple message that can be given out is that these are not the cases where de-escalation is of any great use. At least it has not been proven of any use or any safe use by good quality studies. To the contrary, the limited amount of data which is available, such as the one that I shared out of my own study, unfortunately, they speak against it. They speak against use of any conservation in the axilla for patients who have real axilla, really locally advanced disease both in the breast and in the axilla. So I
Right.
feel we should not even with the available data, we should not even be discussing a option of de-escalation less than axillary dissection in locally advanced cancers.
Right. But if you say, for example, when we said that T4, we should not be considering for a sentinel node biopsy. But whenever a patient comes with a small tumor, but which is superficial and tethered or involving the skin, if
Hmm.
that patient actually responds very well to neoadjuvant treatment, would you not consider her for sentinel node biopsy because she is T4?
Okay, so here you have not such a big but locally advanced because of skin invasion,
Yes,
and the
sir.
patient has responded well.
Yes.
Well, perhaps if the patient was to begin with N0 and
Mm-hmm.
has remained N0,
Mm-hmm.
um, as a policy, I would not uh, mm, offer her sentinel lymph node biopsy yet again because the data suggests so. But if in an individual patient, maybe you can take a value. I mean, very well informed decision if the patient agrees to a need for a second surgery or knowing fully well that what is being done is less than standard of care, maybe you can offer her sentinel lymph node biopsy. But I would also remind the entire audience that what Dr. Kanchan Kaur said is of vital importance. A sentinel lymph node biopsy, or for that matter, surgery, is just one cog in the whole wheel. Let's not forget about multidisciplinary and comprehensive management of these patients. Merely by reducing or increasing the intensity of one component, perhaps we are not going to cure or uh, I mean cause too much of a benefit to the patient. So long as rest of the treatment is all standardized and of high quality, you can very well cover up for one deficiency if in case the patient insisted on not having a full axillary dissection or not having a mastectomy, though you were not very sure about it.
Yeah. Thank you, sir. Um, so now we will actually, I would like to ask Dr. Kanchan, what all factors do you take into consideration whenever you plan a patient for neoadjuvant treatment as to a future, axillary surgery? So what all factors do you consider, and what is your workflow in such a patient about future address of axilla?
So that's a very wide question, and it will obviously apply to what T stage the patient has presented at, what is the hormonal profile of the tumor, what is the indication for doing NACT in that patient. So if we start off with, so you're talking only of CN plus, right? So is it a
Yes.
nodal in an involved axilla in the
Yeah.
neoadjuvant?
Yeah.
Okay.
Yeah. So
So
what are the factors which you feel correlate with axillary CR? And so what is the probability in case if, the tumor size or the tumor biology, what all factors do you consider? So because when we know that we have to start chemotherapy, neoadjuvant chemotherapy, we have to actually think and discuss about the future surgery as well. So we have to take certain steps before we, start chemotherapy. So what all factors you consider, and what is the workflow which you actually
So it's the same algorithm that most breast units would employ, a
yeah.
good clinical examination and evaluation of the axilla clinically, because as Dr. Smithy had very nicely pointed out, most radiologists will put their probe high up in the axilla, whereas what you clinically feel could be very low down. So a correlation of your clinical evaluation of the axilla with a good thorough ultrasound and pre-treatment imaging of the breast and the axilla. Any suspicious nodes obviously to be FNA'd or core biopsied basis what is your local protocol. If it is a heavily involved axilla, large lymph nodes, matted lymph nodes, we do not clip the lymph nodes because such a patient is obviously always going to go for an axillary clearance. But in early breast cancer patients or those who have fewer lymph nodes involved, and when we talk of 2 nodes or 3 nodes, I think that in terms of an ultrasound telling us how many lymph nodes look suspicious, I think that is still a bit arbitrary. But we do know what looks like a low nodal burden in the axilla versus a higher nodal burden. So if
Yes.
only a few lymph nodes are looking abnormal, then the largest node or the most abnormal node in which an FNAC has been done, we do clip that lymph node and have a discussion with the patient that, post neoadjuvant chemotherapy, we will be discussing doing a sentinel node biopsy. But here I would like to let everybody know that I think everyone who is going to enter into that little murky still realm of doing a post neoadjuvant sentinel node biopsy in what was a CN1 axilla, then at least they should be sure that they are able to target that particular lymph node that was FNA. So I am still validating my data. So I am doing a backup axillary clearance still for all patients in whom we have clipped the node. Have only managed to do only about 6 cases in the past 2 years because cost becomes an issue for patients for putting a clip, and then they're still going to have axillary clearance. But I must say we have been able to identify all clip nodes till now, although it is a very small data. So as of now, in a node positive axilla, pre-chemotherapy, even if it becomes node negative on imaging post, my local practice is still to do an axillary clearance. But how high I will go in the axilla is slightly definitely guided by what the pre-chemo imaging was, and also during surgery. As we are operating, if we do keep feeling nodes high up in the axilla, the patient will have a clearance which will go beyond the PEC, up to level 3 and beyond. Yes.
Right. Okay. So as a policy, you also agree with Dr. Gaurav that for N2 and definitely N3, you're not going to go ahead with de-escalation. You would straight away take the patients for ALND in such patients?
Yes,
Is that
even in, so and I'm being honest about this, even in one patients who are node negative post chemo, if we have, if we are not,
चाबी निकाल दो.
we are still obviously proceeding to axillary clearance. But if we have clipped the node, I'm doing a backup clearance at the moment. I think I will slowly take baby steps in early breast cancer towards trying to save the axilla in such patients, obviously after discussion with the patients. But as of now, any node positive pre-chemo is proceeding to axillary clearance post the chemo
right?
in my setting, yes.
Yeah, so the paper which actually Dr. Gaurav mentioned about the Tata Memorial, experience also says that tumor biology definitely supersedes the anatomy and initial node stage. Actually, these are the most important correlates for axillary CR. And again, there are some other, that is hormone receptor status and presence of LVR. So this is actually what are the factors which we need to
So Vishali,
consider
sorry
while
to interrupt. Yeah, so ironically, the more
yes,
aggressive the tumor, a triple negative and a HER2 positive, the
that's
more
correct.
likely, obviously, they are going to get a PCR.
Yes,
And
yes,
the
yes,
less confidence you would feel as a clinician saving the axilla in such patients, because their risk of recurrence is
true,
obviously higher than someone, who's
true.
not a HER2 positive or a triple negative. But
Yes,
also, just very quickly about the Tata study about low axillary dissection. For
yes,
someone who's always done a sentinel node biopsy, I feel that if a sentinel node biopsy is done with the dual technique and a minimum of 3 to 4 sentinel nodes are identified, I don't, at least in my mind, see an added benefit of a low axillary dissection. But yes, in those centers where proper training is not there, and the surgeon doesn't have a large number of experience of sentinel node biopsies, then yes, maybe you could proceed with low axillary dissection as opposed to sentinel.
yes.
Well,
As you
if
rightly
may,
said, yes,
can I come in here?
yes, sir, please.
So our friends from Tata have published and have presented not so good results of sentinel lymph node biopsy, even for patients who had early stage cancer and undergoing primary sentinel lymph node biopsy. And this is contrary to the whole world's literature, including any number of Indian centers. So they may be, I would not like to speculate why their results continue to be less than or poorer than all other centers, though they have one of the largest available patient pool, and nobody can doubt about their expertise and robustness of their systems. So there has to be some explanation why their sentinel lymph node biopsy results are poorer. Now, if you read this paper, if you would find the techniques they use are so different. I mean, for that matter, the injection timing of radiculoid is two hours before the surgery. Well, anecdotally, we have been doing that in certain patients scheduled for first case in the morning. We do injection in the morning, but more
Yeah,
often than not, most centers would do 6 hours to 12 hours before surgery. Injection of methylene blue, most of us, or rather universally, 2 ml of 1% methylene blue, or whichever blue dye you use, is injected either peritumorally or subareolarly, or a combination of the two. Tata, however, uses only zero point 0.5 ml of methylene blue intradermally, and we have seen in the workshops and otherwise they excise that bit of skin with a good, very well placed concern about skin necrosis, because they inject intradermally. Now, if the techniques which they use, they do not yield desired results, I feel there is a need for use of different techniques, perhaps to improve the results they've been able to achieve so far. All this doesn't take away the all the due credit to them that they have devised this low axillary sampling, and which in their hands is working just as much as well as sentinel node biopsy in other people's hands. But
yeah,
when it comes to lower axillary sampling, please do not take it as synonymous with sentinel node biopsy. The basic premise why sentinel node biopsy is done is to reduce morbidity of the axillary dissection. So, logically speaking, the morbidity of low axillary sampling will fall somewhere in between a full axillary dissection and a sentinel lymph node biopsy. It will certainly not be identical with sentinel lymph node biopsy.
right. Thank you. Thank you for your views, Dr. Gaurav.
Can I ask,
But
can I ask for a clarification, Dr. Vishali? From
yes,
yeah, I wanted to ask Dr. Sareen.
yes.
Madam, the axillary sampling that you have talked about is the same as the Tata Memorial low axillary sampling, the one that you are using in.
Smriti, what I alluded is that we do the sentinel lymph node biopsy by a double technique
Yes,
and by scintimammography in addition.
yes.
If we do not have three or more than three lymph nodes in the sentinel lymph node,
Okay.
then we also do a low axillary dissection to get to the 3 or 4 lymph nodes, especially in those who change from CN1 to CN0, because we don't want to go wrong with these patients. We don't want to leave even one micrometastatic disease behind.
What I
So
understand that if
yeah, because our series said if you have three or more than three, the false negative rate was 2%, as against 20% if it was one lymph node. So we have to get more number of lymph nodes, and though the overall follow up is only 3 years, but none of our patients have developed a lymphedema or a neuropathy or a shoulder disability. It just depends on how careful you are at the time of doing sampling, because second intercostal brachial nerve, we take care to save it. It's there
right.
in your dissection area, so save it. And I just want to add on to one more thing, that NCCN guidelines, the Guinea 1 trial, which is 700 patients in clinically node negative prior to the neoadjuvant chemotherapy. Sentinel lymph node is the order of the day.
Yeah.
CN0 before neoadjuvant chemotherapy, and that is why I think it's important pre neoadjuvant to do excellent ultrasound and to do an MRI and
I,
to do clinical examination and make sure this patient is CN0 and not CN1.
I
Yeah.
want to
So,
add a point here, ma'am. I completely agree with you that if the ultrasound evaluation is done well,
Yeah,
you may not need clipping. So I would like to agree with you, because in our series, we realized that just the post NACT ultrasound, the sensitivity and specificity was very high, even without the clipping. So
right,
it is not really essential to do the clipping, but
right,
provided a dedicated ultrasound is
right,
being done
right,
before and
right.
after anything.
We
right.
even add a dedicated MRI, contrast enhanced.
I bet that is because it wouldn't have so much of operator dependence and you can
Right.
see the images, but ultrasound scores over MRI
Yeah.
even.
Yeah.
For
So
Right.
that's exactly what I actually was coming to, Dr. Spriti. In addition to the beautiful presentation you did on, the role of ultrasound, I was actually going to ask you about your take on MRI as a tool for axillary response assessment. So can you please elaborate a little bit on that?
I do not have a very great experience with MRI for axillary nodes, because
Okay.
we are not doing as many MRIs as the private setups are. We only do it for problem solving, and the MRI really has no specific features because it only relies on the size, and the enhancement is same in a reactive node or in a malignant node. So I would
Okay.
rather not feel very comfortable using MRI for response assessment in lymph nodes, because the enhancement of the normal nodes is as much.
Right.
So,
So
so
probably MRI helps us more in, assessing the response in the primary, in the breast
exactly,
primary.
exactly. I don't
Uh,
use MRI for node assessment.
Dr.
yeah.
Smith, if I'm correct, sorry,
Yeah.
Yeah.
the way you position, what I was led to believe is that the way you position the patient in when the patient is lying in the MR machine, the axilla doesn't get covered as
You have
well.
to
So,
make a special
yeah.
sequence
So
with
for
the
the,
body coil to include the axilla in the
it
coronal.
will, otherwise the routine MR will not.
Yes. So since
Yeah.
but
So even if
Can I
MRI, yeah.
Dr. Smriti, recently there was a presentation in which there was a mention of an axillary coil.
Right.
So can you just clarify about the availability of
Yes.
whether an auxiliary coil is something which can be easily made available, and does it offer, how much advantage is there for axillary assessment with the auxiliary coil?
Axillary coil would be a very specific thing and especially useful if you are doing SpIO2, special contrast agents for lymph nodes. So that is one situation, but otherwise I really don't see the use for such a coil.
But
It will
what about,
basically be a surface coil. Yeah.
but what about the breast coil against a body coil?
Ma'am, breast coil will not include the entire axilla, so you have to switch to the body coil and take a coronal scan for the axilla if you want to see the axilla from level 1 to level 3.
Right. Dr. Sareen, there was a question from the audience about, carbon tattooing. So do you have any experience of doing carbon tattooing and doing sentinel node biopsy in these patients?
Vaishali, I
Yes.
do not have it. I'm still looking for a sterile carbon
Exactly.
particles in the market. You know,
Yes.
I have
Not
not been
available,
able to.
ma'am. Not available.
It is not
Because
available.
because to inject that, it has to be sterile, and we have to have the permission of the ethics committee and all that kind of.
I tried hard
Right.
for it while planning the study so that we could try out the tattoo, but the tattoo is not available in India.
And so is iodine 1 to 5 not available in
Like,
India.
we need to do something about that for sure.
We
The
need to do a
radioactive heat.
low axillary dissection in addition to sentinel lymph nodes.
Right. So with this, now we move on to our medical oncology colleagues. Dr. Shefali.
Yeah.
Yeah, so we know that there are certain subgroup of patients who actually, although they are high risk per se, especially the HER2 positive and triple negative patients, but they respond very well to neoadjuvant treatment. So my question to you is, so whenever you plan neoadjuvant treatment, what do you change your strategy based on the nodal burden and the tumor biology? So how do you plan your neoadjuvant treatment to achieve the maximum possible response rate, pathological response rate? So do you plan your do you change your strategy of neoadjuvant treatment based on the nodal burden or the biology? How do you plan it?
Yeah. So, I mean, if I systematically categorize patients into hormone positive versus triple negative versus HER2, of course, the strategy would matter. So,
Yeah.
any hormone positive patients, I would not be looking something as a PCR rate, okay? Because we
Yeah.
know that with the neoadjuvant kind of treatment, the PCR rate would be, say, around 20% at max. And
Yes.
once I am looking forward to a triple negative, so anthracycline would be my most important drug in which I can rely on, and followed by taxanes. So the dose
Okay.
dense regimen would of course be on my cards and would prevail as a first choice. Now,
Right.
when I come to HER2 positive patients, so here is the subgroup of patient where I have a choice depending upon in what subgroup of patients I am doing the neoadjuvant kind of setting. Of course, in a
Right.
heavy nodal burden and increased T side, I would like to add on the pertuzumab advantage in the neoadjuvant. Of course, the cost constraint and the other constraint with the patient need to be taken into consideration. So if
Yes.
I think about the maximum benefit achieved, Perjeta would be on my cards. But of course, now the Catherine data coming in, how reliable I should place on my card on pertuzumab is still to be looked into. So this
Right.
would be my take. So I would have a clear discussion with my patient about the benefits and pros and cons versus the constraint of the patient, and then would choose my line of new adjuvant in HER2 positive subset.
Yeah, so thank you. And this again leads to a second question. When as you rightly said, that in hormone receptor positive patients, you are not looking for, pathological CR. But in patients who are HER2 positive and triple negative, on the one hand, we see that these patients respond excellently to the neoadjuvant treatment, and they are more likely to be clinically node negative, and maybe that we will be offering sentinel node biopsy to these patients. And when we consider a false negative rate to the tune of say 10 or 12 up to 14%. How comfortable are you to take that sentinel node negative status, especially in case of triple negative breast cancers and HER2 positive breast cancers, wherein we know that as Catherine and this oral capecitabine actually adds to the survival benefit. So don't you think that those patients who undergo sentinel node biopsy, these subset of patients, are likely to be undertreated if they are actually sentinel node negatives? What is your take on this?
Yeah, so one thing I would agree, the papers are coming on that. Okay, post neoadjuvant chemotherapy, you can very well practice in a sentinel lymph node biopsy in those patients. But on the other hand, I would agree with Dr. Kanchan and other speakers that you have to selectively and very carefully choose your patient subgroup, because you are deciding such treatment in very high risk young women in whom we do not want even to miss a, like Dr. Sareen ma'am said, we do not want to even miss a micrometastatic node. So in
Right.
those patients with a heavy burden, nodal burden to start with, so my reliance would not be absolutely on sentinel lymph node biopsy. Of course, whether the TPM1 is into place, whether Perjeta is into place, or whether CreateX is the study which is. So the a good response or a pathological response is what is something I'm looking forward to.
Right.
And with a low volume burden, I'll be more confident with a PAT-CR report rather than with a heavy nodal burden and PAT-CR and going in for a sentinel lymph node biopsy in those patients.
Right, right. So to begin with, so the clinical stage at presentation would actually take a precedence over whether the patient has actually achieved a clinical node negative status or not. When we actually think about adding these, adjuvant systemic treatment, especially to these high risk group patients, isn't it?
Yeah, yeah.
Yeah. So we now actually move on to our radiation oncology colleague, Dr. Tripti. I would actually be asking you, what is your take on radiation after sentinel node biopsy in these scenario, especially if the patient was clinically node negative and now the patient has actually undergone sentinel node biopsy and is sentinel node negative. So what all factors would you consider before planning radiation, or would you offer radiation to these scenarios, especially if the patient is sentinel node negative or if the patient has micromets in sentinel node? So what is your take on radiation planning in this scenario?
So thank you, Dr. Vaishali. Like, I think my decision will be always based on the baseline nodal staging. If it would have been clinically N0, based on clinical and radiological findings and guided FNAC if needed, and it comes out to be CN0, and post NACT it is YPN0, then probably that patient may not merit radiation and can be observed further. But if the clinically it was N positive, as Dr. Gaurav has very well elaborated in his last slide, if it is clinically node positive baseline, then there may be two categories after NAC, like after neoadjuvant chemotherapy. Like, one is normal axilla and there are no lymph nodes, and you do the sentinel lymph node. After sentinel lymph node biopsy, even if it is like isolated tumor cell, micromets, or the macromets, I would prefer to go for axillary lymph node dissection is to be done in view of scarce literature. There are ongoing studies which are studying, but the results are awaited for that. So I think in case of micromets, macromets, or the ITC, like axillary lymph node dissection is to be considered. But if the clinically node positive and in the after post NACT, the nodes comes out to be like negative post SLNB, then also I think I would like to give radiation to the axilla.
Okay.
Then also
Especially, so in case if the patient is hormone receptor positive and has a single micromet in sentinel node, would you be post-NACT, yes? Would you be comfortable offering only radiation and not, what will be your radiation field in this patient, if at all you consider?
So I think I don't have a definite answer in view of scarce literature. We don't have a data to support anything, but in case of a positive lymph node, if patient is comfortable to go for axillary lymph node dissection, that is to be offered. If not, then I would treat the whole axilla as per Ambrose trial. Like those fields to be considered as per Ambrose, the complete axilla is to be treated.
Okay. We come across, I'm sure all of us have come across such a situation when the patient has actually been evaluated elsewhere and has been treated with neoadjuvant treatment elsewhere, and the patient has come for surgery to us. And when we see that clinically the patient is node negative. So this is for surgeons as well as for Dr. Kanchan actually, and then later on for Dr. Tripti. Would you be comfortable doing sentinel node biopsy without knowing the clinical nodal status at presentation?
So we are often, faced with such situations if the patient has had treatment elsewhere, chemo elsewhere, and then end up having surgery with us. And it has to be individualized per case basis. In fact, yesterday only I did surgery on a 32-year-old whose pre-chemo imaging from her hometown did not show any involved nodes at presentation. And she had chemotherapy for a small tumor because it was triple negative. So explained to her, she was not happy to have an axillary dissection because I wasn't very confident with the radiologist who done the ultrasound. We did have a PET CT pre, so basis that did a sentinel node, 4 nodes, all came negative. So I'm feeling relaxed from that point of view. But I honestly feel that if you're going to do a sentinel node in a post-chemo patient, then preferably the ultrasound pre-chemo should have been done by a radiologist who you trust is able to evaluate the axilla properly. And in the same note, contradicting my own self, if you feel an absolutely normal axilla, post chemo and pre chemo imaging, even if dubious, didn't show involved nodes, it's very difficult to go ahead and do an axillary clearance basis, just conjecture. So I think this is where it has to be a discussion between you and the patient, a very clear evaluation of whatever is available in terms of pre-imaging and whatever extra imaging you can do before you plan the surgery.
Right. So, sorry.
So, Dr. Vaishali,
in this scenario, when we know that the clinical stage at presentation is actually very sketchy, we do not know about what was the nodal status. And now Dr. Kanchan has operated on this patient and she's node negative, sentinel node negative. What will be your plan for radiation? Would you be
considering Dr. Vaishali, we don't have a baseline nodal staging, and as Dr. Kanchan told, the ultrasound was done somewhere and it's highly subjective. We cannot rely on that. So, and we cannot even deny the false negative rates in post-NACT sentinel lymph node biopsies. They are by the tune of 10 to 30%. Even if the sentinel is negative, I would like to treat axilla by radiation.
Axilla, you will like to treat axilla.
So this patient, sorry, Vishali, was undergoing breast conservation. So I knew she was going to have radiotherapy.
Okay.
Decision becomes more difficult if it is a mastectomy.
Mastectomy.
Because then the big question mark on radiotherapy comes in.
Yes. Yes. Yes.
But Vaishali, I just want to ask everybody in the panel that we all know that sometimes the patients really respond so well. You know, I mean, with the first cycle, you can see the tumor has disappeared. And with 50% PCR rate, you know, PCR rate you can't miss because it's the pathologist telling you there are no lymph nodes and no tumor in the breast. With 50% PCR, and if you are really looking at it dedicatedly, the whole axilla post neoadjuvant, I see. And the radiation, people are going to come and give the radiation. So if you do level 2, level 3 and get the radiation, you're going to get lymphedema. 30%, 40% you are. I mean, they are going to give radiation anyway with a CN positive. Pre-neoadjuvant. So if you can do a good sentinel lymph node and good assessment of the axilla post NSCT, I mean, I feel confident if you have 3 or 4 lymph nodes and they are negative, and even the low axillary is negative. And I don't think, I mean, maybe we don't have a data, but I think the lymphedema is not much higher. If you do a very good low axillary dissection and sentinel lymph node, I think. I mean, I don't have a big data. I can look into that. But the response rate is so phenomenal, and you feel so bad to take out 25 lymph nodes and it's zero involvement. That's
Right.
what is I mean, my heart really cries when it's 0 out of 25, and then you see people with lymphedema, and it's so hard.
Yes.
I mean,
Yes.
that's my just, I'm just saying out of my heart.
Yeah.
Totally agree with you, ma'am, on that.
Yeah.
It's heartbreaking to see 30 nodes negative, even
Yeah.
Correct.
Can I
Yes.
So, sorry.
Yes, sir.
Ma'am, one that with my radiation oncologist, I have a very clear understanding. It's been 25 years in practice. If I have done axillary dissection, no axillary RT is given. 25 years, I make
Right.
it point, no axillary RT. So
Right.
that is something where you have to put your foot down
Right.
and ensure that axillary RT, when an axilla has been dissected, completely has no role.
Right.
That is, so Dr. Arun, that point is very clear. Like if the complete axillary dissection is done, then we don't consider that
Okay.
patient for the radiation. It is covered by tangential only.
So once
If
an
in the
axillary
case
dissection
of
has been done, no RT. So
no
that
RT,
there
that
RT
is pretty
not
clear.
there.
Yeah, that is pretty
Okay.
clear.
Secondly, when we talk of edema, nowadays we read the article where they introduce the sound trial. They say 8 to 10% rate of lymphedema after sentinel lymph node biopsy. So
Yes.
lymphedema rate after sentinel lymph node biopsy is not 0. It is still 7 or 8% is significant.
Dr.
Right.
Arun, may I,
But
I'll tell you a very interesting story. I went to MSKCC, I think 17, 18 years ago, and wanted to see how they did their sentinel node biopsy. If you ever happen to see how a few surgeons there did sentinel node biopsies, you'll understand why lymphedema rates of 8% are quoted with the sentinel node biopsy. If you're not doing a proper targeted sentinel node where you're only taking out that node rather than taking out a blob of tissue with the node, your lymphedema rates will be higher. And I'm sure for all of us who do sentinel node biopsy, just focusing on the node and not taking out too much tissue around it, our lymphedema rates are, I don't even remember one patient who's had a lymphedema.
right. Same here.
Right.
I think
So
that
the
depends on
quality of surgery also matters a lot.
I totally believe that if you have not disrupted axillary lymphatics while doing a proper sentinel node, there is absolutely no reason for lymphedema to happen.
Yeah, I think that comes from experience.
Yes.
That absolutely comes from experience. So
To move on, actually, I would like to ask one last question to anybody who has an experience with neoadjuvant hormonal therapy. So, is there any possibility of sentinel node biopsy in the scenario of neoadjuvant hormone therapy? Does anyone have any experience of this? Although it is not the topic of today's seminar, but ma'am,
Can I take that?
Yes,
Sorry.
sir.
Yeah.
Yes, sir.
Okay, so this pandemic has forced us to use neoadjuvant hormone treatment more than what, I mean, in these last 9 months, I've
Yes.
put more women on neoadjuvant hormone treatment than my entire career put together.
Yes, we agree.
And
We agree.
and
Yes.
and now we are operating many of those women. Some who have completed 5 months, 6 months, 9 up to 9 months of neoadjuvant hormone treatment. And
Right.
recently we did have this discussed in our department meeting, and then we found that women who were N0 to begin with, and we had to put them on neoadjuvant hormone treatment. These were elderly women who you did not want to operate and take a risk of them contracting COVID. And they perhaps had either T2 or T3 disease. They more or less have had similar stage of disease even after 5 months or 8 months. And so I see, if the overall picture has not changed, had I operated these women as primary surgery, why should I not do exactly the same thing now? after a few months of neoadjuvant hormone treatment. So
Mhm.
the point I'm making is, if the woman was N0 to begin with, continues to be N0 at the time of surgery, perfectly fine to offer them sentinel lymph node biopsy. But
Mhm.
if the woman had a nodal positive disease, continues to have a enlarged node, or in my experience, I haven't had any woman who was N1 to begin with and has become N0 now. So, but that hypothetical condition, if it comes to it, I do not have an answer to that.
Okay.
Yeah, but Dr. Gaurav,
Yes.
we all know that hormone receptor positive disease with the hormones, in fact, with the chemotherapy also, the response rate of the PCR is about 15%. So it's very little as against the triple negative and HER2 positive. So that is why anybody who is hormone receptor positive and HER2 negative, we like to operate on them even if they are N1, N1, not N2, N3, but N1. But even in N0, in triple negative and HER2 positive, we would like to give them chemotherapy. So, and I just want to tell you that one of our patients only yesterday has a locally advanced disease, Ki67 of 5%, hormone receptor positive, HER2 negative, and our medical oncologists are saying, no, she needs chemotherapy. We cannot put her on hormone therapy because it will take 4 months to respond. Even then, the response is partial. Even then, you won't be able to do skin saving surgery. I mean, you won't be able to, skin will not be able to, you won't be able to close the skin. So, what I'm trying to say is, even today, our medical oncologists are all for chemotherapy and not really hormone therapy.
Dr. Shefali, would you like to say something to
No,
this?
Pandemic or
no,
no
no.
pandemic.
Ma'am has been my teacher for so long, so I cannot contradict her, and I don't want to actually. So,
No, no.
in a hormone positive, I completely agree with ma'am, where we are not looking forward to a PCR rate. So, the only indication of chemotherapy is the downsizing and nothing else. I'm not looking forward to any event-free survival, any advantage in achieving a PCR. So, I would not argue with ma'am on that. So, rest other things I would like to always learn from her, actually.
But you
Well,
would like to give
if I may
Yeah.
just
neoadjuvant chemo. Yeah.
bring this discussion back to perspective
Yes,
of
sir.
neoadjuvant hormone treatment, we are talking strictly for women who are hormone receptor positive and being treated with hormone treatment and not
Right.
with chemotherapy. So
Right.
I do
Yeah.
not have a figure. I do not know of any large study which has provided a PCR rate following NAHT. I haven't had any experience with N1 turning N0, but I suppose so do others. I mean, I don't think many people have any experience with operating on women who have received neoadjuvant hormone treatment and doing sentinel lymph node
Yeah,
biopsy.
that is true. That is true. But we were talking of neoadjuvant chemotherapy. Also, the response rate is so little. So,
Yeah.
hormonal therapy,
Absolutely.
in any case, is a static disease. It's not. It's not. What it is? The hormone is chemostatic and not
Right.
really chemolytic.
Yeah.
You know what I mean to say? I
Yeah.
mean,
So per
only
se, the experience with neoadjuvant hormonal treatment itself is so low,
very little. Yeah.
especially in our scenario. So
Yeah,
as a result,
COVID has made us to
it's
learn
tough,
these things.
Yeah.
answering this question. Dr. Goel, is there any further question from the audience?
No, I think we have covered mostly. Some of the questions have been answered in the chat, so I think that should.
Right. So with this, actually, I would like to thank all the panelists for such a wonderful discussion on such a debatable topic. So over to you, Dr. Goel, to conclude.
Thank you, Dr. Vaishali. Once again, thanks to our speakers and panelists and all the people who logged in and stayed through this session, though we overshot a bit. But I think we enjoyed it so much that we didn't feel that we are really sort of overshooting. I just want to make a small announcement that on 4th, 5th, and 6th of December, we have a conference on. This is the annual conference for Oncology Forum, which is focused on geriatric oncology. So on 3 days, it's a fully virtual format. We have 27 hours of programming on geriatric oncology with a very good selection of topics. This is something which is not routinely covered in most of the conferences, so would be of interest because we are nowadays seeing at least 15-20% of patients who are 75 and above, and we have to make decisions about lot of treatments. So half of it is about general issues and half of it is focused on various organ systems. So you may find something of interest there. I'll share the registration link through email also to all the people who have registered today. And I think next week after that, Dr. Vaishali, Dr. Geeta, Dr. Shefali, Dr. Tripti, they are organizing a breast cancer focused event, which is having an interesting concept of women only faculty. And I would share in the same email probably the link to that event also. So 2 events which would be very interesting. And because of that reason, and the next event we would delay for about 4 weeks from now. So that is all. Thank you once again. Looking forward to see you in future also. Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.